Usually when we talk about making a medical diagnosis, there's this heavy expectation of mechanical precision. It feels almost like engineering.
Oh, absolutely. It's incredibly binary most of the time.
Right, like you break your arm, the radiologist pulls up the x-ray, there is a jagged white line across the radius, and the doctor simply points to the screen and says, well, there it is.
Yeah, broken or not broken, normal or abnormal. I mean, we derive a lot of comfort from things that are instantly visible and easily categorized.
We really do. But then you step into the world of head and neck anatomy, particularly when we're tasked with looking for the spread of an insidious disease. And suddenly that high-resolution MRI or X-ray machine isn't actually the first tool you reach for.
No, it's not. You're stepping into the absolute definition of diagnostic muddy waters.
Exactly. We find ourselves looking at a diagnostic landscape that is, quite honestly, much quieter, much harder to read if you don't know the language.
Unless, of course, you possess the right conceptual map.
Which is exactly why we are here with you today for another deep dive. Welcome. We are absolutely thrilled to have you sitting in with us.
It's great to be here.
If you are a medical student navigating your early clinical years, maybe a surgical trainee, a dental professional, or honestly, just someone who is deeply curious about how the human body maps its own internal battles, well, you are in the perfect place.
You really are.
Today, our mission is a conceptual synthesis of Chapter 20 from the textbook of Head and Neck Anatomy by Hyatt and Gardner. We are focusing entirely on the lymphatics of the head and neck.
And this represents such a vital pivot from our previous discussions. The whole paradigm of how we think about anatomy shifts here.
It really does. I mean, think about the contrast for a moment. If you were with us for our deep dive into Chapter 19, we spent hours talking about the nervous system.
Which is an entirely different beast.
Totally. The nervous system is constantly shouting at you. It's electrical, it's immediate, and it is impossible to ignore. Pain, temperature, sudden movement. It demands your attention right this second. It's the body's high-speed broadband network.
Fast, reflexive, and very loud.
But Chapter 20, the lymphatic system, it doesn't shout. It whispers. It signals. I like to think of it as this silent, invisible radar or early warning system.
That's a great way to look at it.
It doesn't tell you the stove is hot so you can pull your hand away. Rather, it quietly maps exactly where an obscure infection started weeks ago, where a mucosal cancer might be attempting to spread, and where the body is desperately and visibly mounting a hidden defense.
That framing really establishes the foundational anchor for our entire discussion today, because this deep dive is fundamentally the study of structure in service of function.
Structure in service of function.
Exactly. And crucially, how that anatomical structure dictates disease progression, surgical intervention, and ultimately, clinical outcome. We're not here today to just memorize a dry list of nodes.
Because that won't actually help in a clinic, right?
No, it won't. Rote memorization of Latin names will completely fail you the moment a real patient presents with an atypical swelling. Our goal is to help you build a spatial and functional mental model.
We want you to construct a 3D map in your mind.
Right. A map that a skilled clinician can read with their hands, often long before advanced imaging ever registers a problem.
I love that. Structure in service of function. So we need to start with the fundamental geography and fluid dynamics of this system. Because before we can even begin to talk about where these nodes are located, we have to pause and ask the most basic physiological question.
Which is?
What actually is lymph? Why do we even have a secondary fluid system? We have veins, right? We have this massive, highly pressurized cardiovascular plumbing system. Why doesn't all the fluid just go back into the veins and be done with it?
To understand that, we have to look at a really fascinating problem of biological physics.
Okay, lay it on us.
Well, extracellular fluid is constantly being produced in excess by your circulatory system. As your blood flows through the arterial end of a microscopic capillary network, the hydrostatic pressure, the literal physical force of the blood being pumped by the heart, pushes fluid out through the vessel walls and into the interstitial spaces.
The interstitial spaces being those microscopic gaps between your individual cells.
Exactly. And this fluid bathes the cells, delivering oxygen, glucose, and nutrients.
So the cells are just happily soaking in this nutrient bath, taking what they need.
They are. But then that fluid has to go somewhere once the cells are finished with it. The veins, specifically the venules on the other side of the capillary bed, are supposed to take it back.
Supposed to?
Yes. But the textbook details a critical pressure gradient issue here. The pressure of this fluid within the interstitial tissue out there in the gaps is actually less than the venous pressure of the blood returning to the heart.
Wait, let me visualize that. The fluid in the tissue is at a lower pressure than the fluid inside the vein, so it physically cannot push its way back into the venous system directly.
It simply cannot. It would be trying to flow against the pressure gradient.
It's like trying to merge onto a motorway where the traffic is moving far too fast and the cars are packed far too tightly together.
That's a perfect way to picture it.
You can't squeeze your little car in safely without causing a massive crash. You need a dedicated side road, a slip road, to gather all that overflow traffic, run it parallel to the motorway, and route it back in further down the line where the traffic is cleared and it's safe to merge.
That analogy captures the physical reality perfectly. The lymphatic vessels are that dedicated slip road. Because the interstitial spaces are receiving far more fluid from the arterial end than can possibly be returned at the highly pressurized venous end, this excess extracellular fluid has to find an alternative route out of the tissue.
Otherwise, what happens?
Well, if it didn't, we would literally swell up like balloons. We would be universally edematous. So the fluid finds its way into these microscopic, blind-ended lymphatic capillaries. They have these overlapping endothelial cells that act as one-way miniature flap valves.
Flap valves.
Yeah. When interstitial pressure rises even slightly, the flaps open, the fluid rushes in, and the flaps snap shut. Once it's inside that tube, we stop calling it extracellular fluid, and we start calling it lymph.
And what exactly is in this overflow? It's not just water and spent glucose, is it?
Far from it. This lymph is a highly complex mixture. It contains escaped plasma proteins, huge lipid molecules absorbed from the gut, large particulate matter, and crucially, rogue cells.
Rogue cells.
Yes, molecules and structures that are physically too large to cross back over the venous capillary endothelium anyway. So this parallel plumbing system isn't just a passive overflow drain managing fluid volume.
It's more active than that.
Exactly. It is an active janitorial service. It is constantly clearing the interstitial spaces of cellular debris, mutated cells, and potentially dangerous pathogens.
Okay, so we have this fluid, this lymph, quietly gathering the debris and the overflow from every tissue bed. Now we need to talk about where it goes, specifically when we look at the head.
Right.
And here is where I encountered a structural quirk in the text that honestly blew my mind a little bit. All the lymph nodes of the head are extracranial.
They all sit outside the skull. Every single one.
Which feels entirely counterintuitive to everything we know about how the body prioritizes resources.
It does seem odd, doesn't it?
I mean, the brain is arguably the most important organ in the body. It consumes massive amounts of energy, 20% of our total oxygen. It produces a huge amount of metabolic waste, and it is heavily physically protected by the thick bones of the neurocranium. Why on earth are there no structural lymph nodes inside the cranial cavity guarding it? Don't we want checkpoints protecting the brain?
It does seem paradoxical at first glance. You would assume the most vital organ gets the most robust traditional immune defenses. But the text is explicit. The central nervous system possesses absolutely no lymph vessels. And the biological rule is simple because there are no lymph vessels within the central nervous system to transport the fluid. There can be no lymph nodes inside the neurocranium to filter it.
I'm trying to wrap my head around this. Why wouldn't we evolve vessels in there? Is it a space issue?
Space is a major factor, yes. The brain is encased in a rigid, non-expandable box.
The skull.
Exactly. Lymph nodes, as we will discuss later, swell dramatically when they're fighting an infection. If you had a lymph node deep inside the brain parenchyma that suddenly swelled to the size of a marble because of a viral infection, it would cause fatal intracranial pressure.
Oh, God. It would crush the surrounding neurons.
Exactly. It would be catastrophic. Instead, the brain and spinal cord rely on the blood-brain barrier to keep pathogens out in the first place, and they utilize the flow of cerebrospinal fluid along with the lymphatic system, which is a distinct physiological mechanism involving glial cells to flush metabolic waste out into the venous system.
So, because the inside of the skull is completely devoid of standard lymphatic vessels to save space and prevent lethal swelling, the entire standard lymphatic defense apparatus for the head has to be mounted on the outside.
That is the evolutionary compromise. The nodes must be regionalized or on the outside of the scalp, the superficial face, and the base of the skull. You can picture it almost like a protective extracranial helmet of nodes.
A helmet of nodes.
Yeah, and this helmet catches everything draining from the superficial tissues, the skin, the muscles, the facial expression, and the space is just deep to the facial skeleton, but it catches absolutely nothing from the brain itself.
I love that visual. So let's map out this helmet. Rather than just listing them like a textbook, let's track the journey of a pathogen. Say you are out hiking and you get a nasty tick bite or a deep scratch right on the back of your head, near the crown.
Oh.
Bacteria enters the tissue. Where is the very first place the lymphatic slip road takes that bacteria?
If the scratch is on the posterior parietal or occipital region of the scalp, the lymph fluid now carrying that bacteria will drain posteriorly and inferiorly. It will hit the very back of the helmet. We call these the occipital lymph nodes.
Where exactly are those sitting if I try to feel the back of my head?
There are usually 2 to 4 of these nodes. They're located right at the base of the skull at the back, lying directly on the semispinalis capitis muscle.
Right.
To find them anatomically, you look just inferior to where the trapezius muscle, that large diamond-shaped muscle of your upper back and neck, attaches to the superior nuchal line on the occipital bone.
Okay, so that handles the very back. What if the scratch or an infection, say an infected ear piercing, is on the ear itself or the scalp just behind it?
Then the fluid tracks to the mastoid lymph nodes. Some older anatomical texts refer to these as the postauricular nodes. There are usually 1 to 3 of these. They sit, as the name suggests, right over the mastoid process of the temporal bone just behind your earlobe.
Spatially, they are sitting superficial to the insertion of the sternocleidomastoid muscle, right? That big, thick rope of muscle that bulges out when you turn your head forcefully to the side.
That's the exact landmark. They sit superficial to that tendon. They drain the posterior parietal scalp, the skin of the ear, and importantly, the posterior external acoustic meatus, the back half of your ear canal.
And if the infection is in front of the ear?
We find the preauricular lymph nodes. The text also groups these as the superficial parotid nodes. There are 2 to 3 of these, lying immediately anterior to the tragus of the ear, sitting superficial to the tough fascial capsule of the parotid gland.
So we have established a distinct ring forming the base of this helmet, occipital at the back, mastoid behind the ear, preauricular in front of the ear.
Precisely.
They are gathering all the fluid from the vast expanse of the scalp and the external ear. Now, what about the face itself? The face is incredibly complex, full of separate muscular compartments and cavities. How does the body structure the drainage for the face?
The structural approach to the face is fascinating. It is divided functionally into 3 distinct tiers based on depth. We just mentioned the preauricular nodes sitting superficially on the parotid gland. That serves as our transition into the first tier, the deeper parotid group.
Let's talk about the parotid gland. It's our largest salivary gland, taking up a huge chunk of real estate in the cheek.
It is massive, and it is highly metabolically active. The parotid nodes associated with it can number up to 10 or more. What is unique here is that they form 2 distinct groups. There are nodes lying deep to the gland, right up against the lateral pharyngeal wall, but there are also nodes embedded directly within the substance of the parotid gland itself.
Wait, the gland that makes our saliva is literally studded with the lymph nodes inside its own tissue. Why would they be inside?
You have to consider the embryology. As the parotid gland develops in the fetus, it grows outward and physically engulfs the surrounding lymphatic tissue.
Oh, I see.
Functionally, it places checkpoints right in the middle of a highly active zone. These nodes drain the external acoustic meatus, the skin of the frontal and temporal regions, the eyelids, and even the tympanic cavity, which is your middle ear.
That answers a massive question for me. If a patient comes in with a swollen, inflamed eyelid from a sty or a middle ear infection, that fluid doesn't just evaporate, it tracks down. And the nearest major checkpoints are right inside the cheek in the parotid nodes.
You are tracking the watershed perfectly. That brings us to the second tier, which consists of the superficial facial lymph nodes. There can be up to 12 of these spread across the face.
Where do those sit?
They don't just sit randomly. They follow a very specific anatomical highway. They are disposed sequentially along the course of the facial artery and the facial vein.
So the body uses the existing infrastructure. It takes the slip road and runs it right alongside the main motorway.
Exactly.
If I trace the path of those major blood vessels diagonally across the cheek from the corner of the jaw up to the corner of the eye, I am essentially tracing the lymphatic drainage path.
You are. And within this superficial diagonal group, the text identifies 3 distinct clusters. First, high up, we have the maxillary nodes, also known as infraorbital nodes. They are located right in the vicinity of the infraorbital foramen, just under the eye.
Okay.
Second, moving down the cheek, we hit the buccal nodes. These sit on or directly within the buccal fat pad, overlying the buccinator muscle in your cheek. And third, at the bottom of the diagonal, we find the mandibular nodes. There are usually 2 or 3 of these located along the facial vessels, right where they cross the inferior border of the mandible, sitting adjacent to the masseter muscle.
So, practically speaking, if someone has a severe staph infection right on the bridge of their nose or a boil on their upper lip, the inflammatory fluid is going to track down through those maxillary nodes under the eye, pass through the buccal nodes in the cheek, and eventually hit those mandibular nodes right on the jawline.
Exactly the progression you would expect to palpate. But remember, that is only the superficial face. We still have a massive amount of highly complex tissue deep inside the head. The third tier comprises the deep facial lymph nodes.
This connects so beautifully back to our deep dive on Chapter 12. For our listeners who were with us for that, you'll remember we spent a lot of time exploring the deep face, the infratemporal fossa, and all those powerful muscles of mastication. It's a very crowded, complicated space.
It is arguably one of the most structurally dense regions in the body. The deep facial lymph nodes follow the course of the maxillary artery deep into that infratemporal fossa. Spatially, they sit superficial to the lateral pterygoid muscle.
Right.
These specific nodes are responsible for draining the temporal and infratemporal fossa and the posterior nasal pharynx.
I am visualizing a wisdom tooth extraction gone horribly wrong, leading to a deep space infection in that infratemporal area. The swelling is going to be immense, and it's these deep facial nodes that have to deal with that sudden influx of pus and debris. Are there any other deep nodes we need to be aware of before we leave the head?
The text highlights two additional, critically important groups of deep nodes. First, the lingual lymph nodes. There are usually 2 or 3 of these lying on the superficial aspect of the hyoglossus muscle. They are deeply and intimately associated with the drainage of the tongue, which we will cover in great detail later.
Okay. And the second?
Second, and perhaps more dangerous from an infectious standpoint, are the retropharyngeal lymph nodes.
Retropharyngeal. Behind the pharynx. Why put a checkpoint in the literal crevice behind the throat?
Because of what it guards. There are 1 to 3 of these nodes, and they are located embedded within the buccopharyngeal fascia directly behind the upper pharynx. Spatially, they sit right at the level of the atlas, the very first cervical vertebra.
Right near the base of the skull.
Yes. They sit within the retropharyngeal space. Clinically, this is a notorious danger space because it provides a direct vertical highway for infection to spread all the way down into the superior mediastinum of the chest.
Yikes.
These nodes are placed there because they drain the posterior nasal cavity, the paranasal sinuses, the hard and soft palate, the nasopharynx, the oropharynx, and the auditory tube.
So your entire upper respiratory tract, your main air intake, sends its first wash of lymphatic fluid to these nodes at the level of C1. If you get a severe sinus infection or a bad throat infection, these retropharyngeal nodes are the very first structural defense preventing that infection from tracking straight down your spine and into your chest cavity.
That is their exact functional purpose.
Incredible. Okay, so we have fully mapped the extracranial helmet of the head and the 3 distinct depth tiers of the face. We've collected all this dangerous cellular debris and excess fluid, but the heart, the ultimate destination, is down below.
It is.
This massive volume of fluid has to fight its way through the narrow bottleneck of the neck, and the neck is already densely packed with the trachea, the esophagus, the spinal cord, and massive blood vessels. How does the body engineer a pathway for this much fluid without choking us?
It does it by using the spaces between those major structures to create massive catchment basins.
Catchment basins?
Yeah, if the head and face nodes are the small tributary streams trickling down the mountain, the neck nodes are the Great Lakes where all these complex pathways consolidate and pool. The text outlines several distinct functional groups in the neck to manage this volume.
Let's trace the fluid down the neck. Where does it hit first?
Let's look at the anterior aspect first. The anterior cervical lymph nodes. These are somewhat inconsistent from person to person, but generally they are located in front of the major viscera of the neck. They are subdivided into a superficial group, which lies in an irregular vertical row tracking along the anterior jugular vein, and a much more critical deep group.
The deep group. I'm trying to picture this. They sound like they're physically hugging the airways.
You are visualizing it perfectly. They're tightly associated with the visceral tubes. The deep anterior cervical nodes are actually subdivided into 4 very small, highly specific chains. We have the paratracheal nodes sitting deep in the tracheoesophageal groove.
Let's pause there for the listener. The tracheoesophageal groove, we are talking about the literal physical crevice between the windpipe in the front and the food pipe in the back. Why place a lymph node deep in that specific cleft?
Because that crevice is a watershed for both tubes. If there's a mucosal injury or a cancer developing in the upper trachea or the esophagus, the fluid drains laterally directly into that groove.
I see.
The other chains in this anterior deep group include the infrahyoid nodes resting on the thyrohyoid membrane, The pretracheal nodes wedged between the deep cervical fascia and the anterior trachea, and the prelaryngeal nodes sitting on the cricothyroid ligament. Collectively, this anterior deep group is responsible for draining the thyroid gland, the larynx, and the upper trachea.
So if a patient develops thyroid cancer or a severe laryngeal infection that affects their vocal cords, this deep anterior ring hugging the airway is your first line of lymphatic defense.
Okay, moving away from the airway, what about right under the chin?
That brings us to a highly palpable group, the submental lymph nodes. There are usually 2 or 3 of these. They are perfectly nestled in the submental triangle. To visualize this, imagine the space between the anterior bellies of the right and left digastric muscles, with the mylohyoid muscle forming the floor above them.
Basically, if you take your thumb and press it directly upward right behind the point of your chin, you are pressing into the submental triangle.
Exactly right. Moving slightly lateral and posterior from the chin, along the jawline, we encounter the submandibular lymph nodes. There are usually 3 to 6 of these situated in the submandibular triangle. They lie in very close physical proximity to the submandibular salivary gland.
The text makes an interesting note here. While it's technically a chain of nodes, the only truly constant node, the one you can almost always find across different patients, is the one sitting at the facial groove of the mandible, right where the facial artery crosses the bone.
Okay, we have the anterior airway viscera covered, the point of the chin, the lateral jawline. What about the broad sides of the neck?
Superficially, on the lateral aspect, we have the superficial cervical lymph nodes. There are usually only 1 or 2 of these, and they're very easy to picture spatially. They lie immediately adjacent to the external jugular vein as it runs its course superficial to the sternocleidomastoid muscle.
So if you look at someone straining their neck and you see that big vein popping out over that thick neck muscle, the superficial cervical nodes are riding right alongside that vein.
Yes, they manage the superficial drainage of the skin of the neck. However, the most crucial group in the entire system, the absolute undisputed kings of the cervical lymphatic network, are the deep cervical lymph nodes.
The textbook dedicates a massive amount of space to these. These are the ultimate catchment basins we alluded to earlier.
They are highly numerous, and they form a continuous vertical chain running directly alongside the carotid sheath.
For our listeners who haven't done head and neck dissection recently, let's build that carotid sheath in our minds. It's not just a space, it's a tough fascial tube running deep vertically in the neck. Inside this tube, you have 3 vital structures packed together: the common carotid artery bringing blood to the head, the internal jugular vein draining blood from the brain, and the vagus nerve wandering down to control your internal organs. And these deep cervical nodes are just packed all along the outside of this fascial tube.
You've painted the picture perfectly. They parallel the internal jugular vein within the carotid sheath along its entire length. For the most part, they sit deep to the protective bulk of the sternocleidomastoid muscle. To make clinical sense of this massive chain, anatomists divide them into 2 subgroups: the superior deep cervical lymph nodes and the inferior deep cervical lymph nodes.
Where's the dividing line?
The dividing line is roughly where the tendon of the omohyoid muscle crosses over the internal jugular vein.
So the superior group is higher up, extending from the base of the skull at the mastoid process down to the middle of the neck. And the inferior group resides lower down, occupying the supraclavicular triangle, intimately associating with the brachial plexus nerves and the subclavian vessels just above the collarbone.
That is the anatomical distribution. We should also briefly mention a couple of accessory chains. The accessory lymph nodes accompany the spinal accessory nerve as it crosses the posterior cervical triangle to innervate the trapezius.
Whoa.
And the transverse cervical lymph nodes follow the transverse cervical vessels at the base of the neck, running horizontally near the clavicle.
Okay, let's step back and look at the map we've drawn. It is beautifully complex. We have the extracranial helmet of the head catching the surface drainage. We have the 3 depth tiers of the face managing the complex oral and nasal structures. And we have these massive catchment basins in the neck, culminating in that colossal deep cervical chain wrapping along the carotid sheath.
It's an incredible network.
It really is. Now, we need to transition into the functional integration. The anatomy is static, but the system is dynamic. How does this entire sprawling network actually move the fluid? And crucially, how does it finally reconnect with the main cardiovascular system?
The entire system is governed by the principle of sequential convergence. Lymph flows from those microscopic, blind-ended capillaries we started with into minor lymphatic vessels. These vessels act like small streams, and they're forced to pass through 1 to several lymph nodes along their journey. After exiting a node, these minor vessels merge into larger and larger major lymph vessels.
Small streams converging into rivers, rivers converging into a massive estuary.
And the text emphasizes a critical, non-negotiable anatomical reality. The deep cervical lymph nodes act as the final common pathway. Ultimately, all of the lymph from the entire head and neck, whether it originated from a scratch on the scalp, an infection deep in the face, a tumor in the oral cavity, or inflammation in the thyroid gland, it all eventually inevitably funnels into the deep cervical chain.
That is a staggering bottleneck. So if a virulent pathogen manages to survive the occipital nodes and then fights its way past the superficial cervical nodes, it still hasn't won. It still has to face the massive immune arsenal of the deep cervical nodes before it can gain access to the rest of the body.
The body demands multiple layers of filtration. Once the fluid reaches the bottom of the deep cervical chain, the efferent vessels, the vessels leaving the inferior deep cervical nodes, merge together to form a single large lymphatic vessel called the jugular trunk.
The jugular trunk, a single large pipe. And where does that pipe finally empty its contents? We established in the very first 5 minutes that the whole thermodynamic point of this system is to return the fluid to the cardiovascular system so we don't swell up.
The jugular trunk delivers this collected, heavily filtered lymph back to the massive venous vessels right at the root of the neck. The anatomy differs slightly by side. On the right side of the body, the right jugular trunk usually joins the right lymphatic duct. On the left side, the left jugular trunk joins the vastly larger thoracic duct.
Ah, the thoracic duct. That is the massive vessel that brings essentially all the lymph up from the legs, the abdomen, the thorax, the entire lower body.
Yes. The left head and neck fluid joins that massive upward flow. Finally, from these two terminal ducts, the lymph is emptied directly into the circulatory system at the venous angle, the precise junction where the internal jugular vein merges with the subclavian vein to form the brachiocephalic vein. It dumps into the right and left subclavian veins, respectively.
Which, when you think about the fluid dynamics, is an absolutely brilliant piece of evolutionary engineering. Why dump it there? Because at that specific junction, right before the blood drops down into the right atrium of the heart, the venous pressure is at its absolute lowest point in the entire body. It creates a vacuum effect. This allows the low-pressure, slow-moving lymphatic fluid from the jugular trunk to finally merge back into the high-speed blood traffic without being aggressively pushed backwards.
It is the exquisite, elegant resolution to the hydrostatic pressure gradient problem we discussed at the very beginning. The slip road merges seamlessly back onto the motorway just before the toll booth.
I love when the anatomy solves a physics problem. So we've traced the flow from the capillaries all the way to the heart. Now I want to zoom in on the nodes themselves. Let's talk about what actually happens inside these structures as the fluid flows through them.
Okay.
Because the text introduces this critical concept of the barrier system. If this lymph is carrying dead bacteria, toxic cellular debris, or worse, migrating cancer cells from the interstitial spaces, how does the body safely process all that hazardous waste before dumping it directly into the heart?
This is where the functional elegance of the anatomy truly shines. A lymph node is not just a wide spot in a pipe. It is a highly organized, fiercely guarded biological filter. Inside the node, there is a dense meshwork of reticular fibers. As the lymph slows down to percolate through this maze, foreign substances and abnormal cells become physically trapped.
Like a net.
Exactly. Once trapped, they are attacked. Macrophages, large white blood cells, literally engulf and digest the debris through phagocytosis. Simultaneously, lymphocytes within the node examine the antigens and mount highly specific, targeted immune responses.
I used the analogy of a slip road earlier, but this sounds much more like a militarized border checkpoint.
The border checkpoint analogy is deeply accurate for how clinicians conceptualize this. The textbook describes it formally as a barrier system where the disease agent is actively intercepted and combated. The very first node that receives lymph directly from a specific tissue area is clinically known as the primary node.
The primary node, like the very first passport control booth you hit after crossing a physical border.
Exactly. But biology anticipates failure. What if the disease agent, say, a particularly virulent strain of streptococcus or a highly aggressive metastatic melanoma cell, manages to survive the primary node? What if it overwhelms the macrophages? The efferent vessels carry that surviving threat further down the chain to the next node, which serves as the secondary node.
A second heavily armed checkpoint located further inland.
And if that secondary barrier falls, the fluid drains to a tertiary node. The physiological reality of fighting systemic infection or metastasis is a brutal numbers game. The more individual nodes that are interposed in the disease agent's route of spread before it reaches those major lymphatic trunks, the better the chance the immune system has of successfully destroying the threat and preventing systemic septic ischemia or widespread metastatic disease.
That makes profound clinical sense. If a patient develops a squamous cell carcinoma on the inside of their cheek, those cancer cells have to break off, travel the lymphatics, and somehow survive the buccal nodes, then fight through the submandibular nodes, then run the gauntlet of the superior deep cervical nodes, and finally survive the inferior deep cervical nodes before they can ever reach the bloodstream to seed the lungs or liver. The anatomy provides defense in depth.
And that defense in depth is exactly what clinicians are attempting to measure when they physically examine a patient. Which brings us perfectly to our clinical correlation section, why this intricate anatomical mapping fundamentally matters in a real-world clinical setting.
Okay, let's get into the practical, hands-on application. The text points out something that is so deceptively simple but profoundly important for diagnosis. The lymph nodes of a healthy individual are soft, yielding, non-palpable structures. If I feel my neck right now or under my jaw, I shouldn't really be able to feel distinct, hard bumps.
You shouldn't. They are small, and they blend seamlessly into the surrounding fat and soft tissues. But we must ask what happens when those border checkpoints are actively engaged in a firefight. When there is an acute infection, severe tissue inflammation, or carcinomatous involvement, meaning cancer cells have invaded the node, survived, and are actively multiplying inside it, the microenvironment inside that capsule changes radically.
The immune system rushes thousands of extra lymphocytes to the area to fight, blood flow increases, the trapped fluid builds up rapidly, and the fibrous capsule of the node stretches taut.
That stretching is the key. These constant, anatomically predictable structures suddenly become swollen. They become palpable to a searching hand. They often become indurated or hard, and in the case of a rapid, acute bacterial infection stretching the capsule quickly, they can be incredibly painful to the touch.
So the invisible, silent map we've been discussing suddenly becomes visible, or at least tactile, beneath the skin.
The map reveals itself, and this is the true art of clinical palpation. Because we know that specific nodes receive lymph from relatively specific, predictable areas of the body, a skilled health professional can essentially read the neck like a diagnostic text.
Working backward.
Right. By understanding the routes of lymph flow, a clinician can deduce the general anatomical location of a completely hidden infection or a silent primary tumor, simply by feeling which specific node is enlarged and working backward up the pathway.
The text mentions the technique for palpating the deep cervical chain. Now, we established earlier that these nodes sit deep to the sternocleidomastoid muscle, that huge, thick neck muscle. If they are normally soft and they are buried under an inch of muscle, how do you feel even an enlarged one?
You cannot just press hard. You have to manipulate the anatomy to work for you. A skilled clinician will have the patient tilt their head slightly downward and toward the side being examined.
Loosen it.
Exactly. This action actively relaxes the sternocleidomastoid muscle, turning it from a tightrope into loose tissue. This allows the clinician's fingers to hook gently underneath the anterior or posterior border of the muscle belly and physically trace the firm pulsating line of the carotid sheath, feeling for any hard, fixed, or abnormally enlarged nodes running along that deep cervical chain.
That is a brilliant mechanical trick. And as you are tracing that deep cervical chain, there is one specific node that the textbook gives massive, almost singular importance to. It is located in the superior deep cervical group, and it commands a lot of respect. It's called the jugulotogastric node.
If a listener takes away only one specific anatomical name from this entire hour-long deep dive, it should absolutely be the jugulotogastric node. Its clinical significance cannot be overstated.
Let's paint the spatial picture for the listener. If I'm examining a patient, where exactly am I looking for this sentinel?
It is a notably large, highly constant node located right at the geometric junction of two major anatomical structures. It sits precisely in the angle between the tendon of the posterior belly of the digastric muscle and the internal jugular vein.
I'm visualizing that. So to find it, I go to the angle of the jaw, drop down just a bit into the neck, tuck my fingers under the front edge of the sternocleidomastoid, and I'm feeling right where that digastric muscle crosses the big vein.
That is the exact anatomical location. And the textbook lists several dramatic, functional nicknames for it, which tell you everything you need to know about why we care about it. First, it is widely known as the principal node of the tongue.
Why give it that title? The tongue is huge.
Because it receives thick, heavy lymphatic drainage directly from the lateral portions of the anterior two-thirds of the tongue, The margins of the tongue dump their fluid right into this node
Okay, that makes sense. The text also calls it the tonsillar node.
because it receives massive lymphatic efferents directly from the palatine tonsils and the pharyngeal tonsils. Think back to a time you had severe tonsillitis or strep throat. Remember those massive, exquisitely tender lumps that swelled up right under the angle of your jaw, making it painful to even turn your head. You're likely feeling a massively inflamed, reactive jugulogastric node fighting off the streptococcal invasion.
Oh, absolutely. And then, most chillingly, the text refers to it as the sentinel node.
This is where understanding the anatomy becomes a life-saving skill. The jugulogastric node acts as a secondary catcher, a massive secondary barrier for the submandibular and submental regions that drain the rest of the vast oral cavity. So it is gathering immunological intelligence from an enormous, highly complex mucosal surface.
And the text makes a critical point here that changed how I view oral exams. It drains areas of the oral cavity that are notoriously difficult, if not impossible, to visually examine during a routine checkup.
The deep recesses of the posterior tongue, the absolute floor of the mouth tucked under the tongue, the hidden tonsillar pillars. A patient could have a primary squamous cell carcinoma developing in these hidden crypts, and it might be completely asymptomatic. No pain, no visible ulceration to the naked eye. But the lymphatic fluid is constantly watching over that silent tumor, picking up microscopic shed cancer cells and delivering them straight down the slip road to the jugulogastric node.
Where the macrophages try to eat them, but the cancer cells survive, get trapped in the reticular mesh, and start to rapidly multiply.
Yes, they colonize the node. So, on a routine physical examination, a dentist or physician might palpate the neck and find an enlarged, hard, remarkably painless jugulogastric node. That painless fixed lump may be the very first physical positive sign that the patient has a hidden occult oral carcinoma. It is the sentinel on the wall crying out that the border has been breached long before the invading army is visible.
That is profound. A hard, silent lump in the neck telling you there is a killer hiding in the base of the tongue. This perfectly illustrates your anchor statement anatomical structure, directly shaping disease presentation and surgical intervention. And speaking of intervention, the text delves into a surgical reality that is frankly horrifying when you really think about the implications of the anatomy we've discussed. When those deep cervical nodes are invaded by cancer, when the cancer has established a beachhead in the neck, what actually happens next?
The clinical reality of head and neck oncology is incredibly harsh. If a primary cancer has successfully seeded the nodes of the neck, a condition we call cervical metastasis, the surgical treatment often requires a radical procedure known as a block resection or a radical neck dissection.
I was struck by the absolutist wording in the text. It says, "It is essential that all lymph nodes of the particular side of the neck be removed." You can't just open the neck, find the 3 hard nodes that feel cancerous, and pluck them out like picking bad berries off a bush. Why not?
You absolutely cannot do that. It would guarantee a recurrence of the cancer. And the reason lies entirely in the anatomical continuity we've spent the last half hour discussing. The lymphatic vessels and nodes are not discrete, creely floating pebbles. They are intimately, microscopically embedded within the deep cervical fascia. They are inextricably woven into the delicate connective tissue that surrounds the muscles, the major blood vessels, and the cranial nerves.
Because they track the blood vessels, they are the slip roads running literally attached to the motorway.
They share the same adventitia. They are a microscopic, highly interconnected web. If a surgeon just tries to neatly pluck out the visibly or palpably enlarged nodes, they will almost certainly leave behind microscopic clusters of cancer cells trapped in the intervening invisible lymphatic vessels and smaller, unpalpable nodes buried within that fascial plane.
So to ensure you get every single rogue cell out,
You have to take the entire anatomical block. The microscopic anatomy dictates the gross surgical intervention. To guarantee all potentially cancerous nodes are removed, surgeons historically had to perform a radical neck dissection, which sacrifices vast amounts of surrounding healthy tissue just to get the fascia out. Depending on the extent of the disease, they may have to completely sever and remove the sternocleidomastoid muscle, excise the submandibular salivary gland, ligate and remove the internal jugular vein itself, and tragically sacrifice critical nerves like the spinal accessory nerve, which controls the trapezius and allows you to lift your shoulder.
so a patient might wake up completely cured of the primary cancer, but permanently unable to lift their arm above their head or turn their neck properly, suffering from chronic shoulder drop and pain, all because the lymphatic system is so deeply physically integrated with the musculoskeletal system. It really drives home why catching it early at the sentinel node before it tracks down the entire deep cervical chain and necessitates a radical dissection is so utterly critical.
It is the stark difference between a minor localized resection and a permanently life-altering, disfiguring radical dissection. The anatomy demands respect.
Let's take a breath. We've looked at the terrifying big picture of the neck. Now, I want to pivot to the integration section, specifically keeping our many dental and surgical trainee listeners in mind. We need to look closely at the incredibly specific oral and dental map provided in the text. Let's trace the drainage of the teeth and the gums. If I have an infection in my mouth, where does it go?
The text provides a very precise, clinically useful routing system here. Let's start with the soft tissues, the gingiva or the gums. Lymph from the gingiva is gathered continuously on both the lingual side, the inner surface facing the tongue, and the vestibular side, the outer surface facing the lips and cheeks. This fluid is collected by vast, microscopic submucosal plexuses of lymph vessels.
Just a rich, invisible sponge network right under the surface of the gums.
Yes. These delicate plexuses consolidate into a series of larger vessels that generally run posteriorly, heading toward the back of the mouth, behind the molars. From there, the lymph mostly passes downward into the submandibular lymph nodes. Occasionally, some vessels might take a shortcut, bypass the submandibular nodes, and drain directly into the deep cervical chain. But the submandibular nodes are the reliable primary destination for gingival fluid.
What about the hard structures? The teeth themselves, the living pulp inside the tooth chamber, the periodontal ligament holding the root tightly in the bony socket.
The text notes that lymphatic vessels exiting from the pulp and the periodontal ligament of the same individual tooth generally merge and share a common drainage vessel exiting the jawbone. While there is always some debate in the broader anatomical literature about minute variations, the textbook provides a very firm, reliable rule of thumb for dental drainage that all clinicians use as a baseline.
And what is that golden rule?
It is all about separating the front bottom teeth from literally everything else in the mouth. The mandibular incisors, the forefront, flat teeth right in the middle of your lower jaw, drain their lymphatic fluid directly straight down to the submental lymph nodes, located right in the submental triangle under the point of the chin.
Okay, that's step one. Mandibular incisors go straight down to the submental nodes.
Step two is everything else. Every other tooth in your head, all the maxillary teeth in the upper jaw, meaning incisors, canines, premolars, and molars, and all the remaining mandibular teeth, meaning the lower canines, premolars, and molars, drain to the submandibular lymph nodes positioned along the jawline.
That is a brilliant, simple spatial rule to commit to memory. Bottom front four go to the chin. Everything else in the upper and lower arches goes to the jawline. Let's put that into a diagnostic scenario. Imagine you have a patient sitting in your dental chair. They present with a massive, hard, painful swelling right under their chin in that submental triangle. As a clinician, your immediate instinct might be to suspect a throat infection or a skin boil.
But if you know this specific anatomical map, you know that before you refer them to a throat specialist, you absolutely must ask them to open their mouth, take your mirror, and tap on those 4 lower front incisors to check for a necrotic pulp or a deep periodontal abscess.
Because the map points straight back to those 4 teeth.
It does. And there is one more vital principle regarding the laterality of drainage that we must cover. Generally, lymphatic drainage is strongly ipsilateral. That means it stays strictly on the same side of the body where it originated. The right maxillary molars drain to the right submandibular nodes. The left mandibular premolars drain to the left submandibular nodes.
That makes logical sense. Keep it on your own side of the highway, but I hear a caveat coming.
There's always a caveat in biology. For anatomical structures located very near the sagittal midline of the body, like the central incisors, the very tip of the tongue, the central portion of the lower lip, the lymphatic vessels freely cross over. Drainage from the midline can be both ipsilateral and contralateral. It can cross the street.
So a severe, isolated infection in a lower right central incisor could theoretically present as a swollen submental node on the left side of the patient's chin.
Yes. That contralateral crossover is a critical diagnostic trap. If you see a swollen left node and you only examine the left teeth, you might miss the massive abscess on the right central incisor because the fluid crossed the midline.
Speaking of complex, confusing drainage patterns, we absolutely cannot leave the oral cavity without discussing the elephant in the room, the tongue. The text describes the tongue as having a rich lymphatic plexus. Given how it moves, it seems like the most complicated organ in the whole head and neck region to map accurately.
It is highly complex because it is a massive, highly muscular, highly active organ that spans multiple anatomical compartments, from the front of the mouth all the way down into the pharynx. And the lymphatic drainage from the right and left sides is heavily intermingled, especially toward the midline fibrous septum. However, despite this complexity, the text beautifully categorizes the tongue's drainage into three precise, distinct pathways to help us build a workable mental model.
Okay, let's break down the three distinct pathways of the tongue for the listener trying to visualize this.
Pathway 1 deals with the tip of the tongue. Lymphatic vessels from the very tip, along with the mucosal region of the lingual frenulum directly underneath it, drain inferiorly, passing through the mylohyoid muscle to end up in the submental nodes.
That makes perfect spatial sense. The tip of the tongue sits right above the lower incisors, so it drains to the exact same place straight down to the chin.
Exactly. Now, pathway 2 deals with the lateral aspect of the anterior two-thirds of the tongue, the sides of the tongue that touch your cheeks. These areas are drained by marginal vessels that sweep laterally and backward, draining directly into our famous sentinel, the gigalotogastric nodes of the superior deep cervical chain.
Which perfectly explains why we earlier called the jugulotogastric the principal node of the tongue. It takes the brunt of the fluid from the sides, where many oral cancers tend to form.
You've made the perfect clinical connection. Now, pathway 3 is the most complex because it handles the deepest structures. It involves the central vessels draining the thick medial region of the anterior two-thirds and the dorsal vessels draining the region of the sulcus terminalis and the massive posterior one-third of the tongue, the base of the tongue.
So the thick middle core of the tongue and the very back part sitting down in your throat, where does all that fluid go?
These deep vessels bypass the upper nodes entirely. They eventually deliver their heavy lymphatic load to a specific node located much further down the cervical chain, the jugulo-omohyoid lymph node.
The jugulo-omohyoid node. We haven't focused on that one yet. Where exactly is it located in the neck?
It is a large, highly constant node belonging to the inferior deep cervical group. It is located, as the name heavily implies, right near where the intermediate tendon of the omohyoid muscle crosses over the internal jugular vein.
So physically, it is sitting much lower down the neck, almost near the collarbone, compared to the jugulotogastric node, which is up high near the jaw.
Yes,
Right.
which presents us with a fascinating anatomical paradox. The base of the tongue, which is physically higher up in the head, is drained by nodes situated more cranially than those that receive lymph from the tip of the tongue. It's a complex, almost inverted drainage pattern.
Why would the body build it that way? Why cross the streams?
It likely relates to the complex embryological origins of the tongue, developing from multiple different pharyngeal arches that bind their own lymphatic networks with them as they fuse. Functionally, it ensures that the massive lymphatic output of such a large active organ is distributed and handled by the massive capacity of the deep cervical chain at different levels, rather than overwhelming a single node cluster.
Okay, let's take a deep breath and distill our key takeaways from this massive, complex anatomical synthesis. If a listener remembers nothing else from the last hour, what are the core concepts they need to hold on to tightly?
Let's solidify the mental model. Number 1, function dictates form, and physics dictates flow. The lymphatic system exists fundamentally to collect the excess interstitial fluid, plasma proteins, and dangerous cellular debris that high venous pressure physically prevents from re-entering the capillaries. It is an absolutely necessary parallel, low-pressure plumbing system.
Number 2, the barrier system. Lymph nodes are not random lumps. They are constant, anatomically predictable structures acting as sequential border checkpoints, primary, secondary, and tertiary barriers. They are packed with macrophages designed to phagocytose pathogens and trap cancer cells before they can reach the central blood supply.
Number 3, the extracranial anomaly. Because the delicate central nervous system lacks lymph vessels entirely to prevent lethal swelling, all nodes of the head are situated strictly outside the skull, forming a protective extracranial helmet. And crucially, all of this complex head and neck drainage ultimately funnels into the massive, deep cervical nodes along the carotid sheath. They serve as the inescapable final common pathway.
Number 4, the sentinel. The jugulo-digastric node, predictably located exactly where the digastric muscle crosses the jugular vein, is the clinical alarm bell. It is the principal node of the tongue and the tonsils, and a hard, swollen jugulo-digastric node is often the very first sign of a hidden, silent oral carcinoma.
And finally, number 5, the map matters for diagnosis. Knowing the precise rule-based anatomical drainage, like the firm rule that mandibular incisors drain to submental nodes, while the remaining teeth go to submandibular nodes, allows a clinician to reverse engineer the hidden path of a disease. You feel the palpable node, and your trained anatomical mental model traces the unseen path backward to discover the hidden source.
That is a phenomenal, comprehensive summary. And to ensure that 3D mental map is firmly locked into your brain, we are going to transition into our active recall segment. We have 5 single best answer, or SBA, questions designed to specifically test your spatial reasoning and functional understanding based directly on the textbook material we just synthesized. Listeners, wherever you are, try to mentally commit to an answer before our expert breaks down the clinical logic.
I am ready to dissect the options.
Okay, let's test the map. SBA question 1A, patient presents to your clinic with an enlarged, hard, palpable node located precisely between the anterior bellies of the digastric muscles. Based on lymphatic drainage pathways, which of the following structures is the most likely primary source of an occult infection or malignancy draining to this specific anatomical location? Option A, palatine tonsil. Option B, mandibular incisors. Option C, posterior third of the tongue. Option D, maxillary molars.
The clinically correct answer is B, the mandibular incisors.
Walk us through the spatial and diagnostic logic you use to eliminate the others.
The key to the question is confidently identifying the node's location from the anatomical description between the anterior bellies of the digastric muscles. Spatially, that perfectly defines the borders of the submental triangle. Therefore, the clinician is palpating the submental lymph nodes. According to the textbook map we just discussed, the submental nodes receive primary drainage from the mandibular incisors, the very tip of the tongue, the central lower lip, and the skin of the chin.
And why are the other options dangerous diagnostic traps if chosen?
Option D, the maxillary molars, completely violates the dental drainage rule we discussed. All teeth except the lower front 4 drain laterally to the submandibular nodes, not to the submental midline. Option A, the palatine tonsil, drains its fluid directly to the sentinel, the jugulo-digastric node at the angle of the jaw. And option C, the posterior third of the tongue, drains deep and low to the jugulo-omohyoid node. So option B is the only anatomical fit for a midline submental swelling.
Excellent breakdown. SBA question 2. Why are there absolutely no lymph nodes located deep within the cranial cavity to drain the brain directly? Option A, intracranial venous pressure is too high to allow for lymph formation. Option B, the central nervous system possesses no lymph vessels. Option C, intracranial lymph drains directly into the thoracic duct without needing nodes. Option D, the cerebrospinal fluid actively destroys lymphatic vessels.
The correct answer is B, the central nervous system possesses no lymph vessels.
This was the major counterintuitive point of our earlier discussion about the extracranial helmet.
Yes. While we debated the evolutionary reasons for this, like the danger of swelling inside a rigid cranium, the textbook explicitly provides the anatomical reason. The lymph nodes of the head are all extracranial simply because there are no lymph vessels within the CNS tissue itself to connect to them. Without the plumbing infrastructure, you cannot have the filtration stations. The other options are well-crafted distractors. While venous pressure and CSF are highly relevant to overall brain physiology and fluid dynamics, the explicit foundational anatomical reason given in the text for the lack of nodes is the absolute absence of lymphatic vessels themselves.
Brilliant. SBA question 3, surgical oncologist is examining a patient and specifically wants to palpate the jugulo-digastric node to check for metastasis from a tongue lesion. Where exactly in the neck should they direct their fingers to locate this specific sentinel node? Option A, along the external jugular vein, superficial to the sternocleidomastoid muscle. Option B, in the tracheoesophageal groove, deep to the thyroid gland. Option C, at the junction of the internal jugular vein and the posterior belly of the digastric muscle. Option D, in the vicinity of the intermediate tendon of the omohyoid muscle.
The correct answer is C, at the junction of the internal jugular vein and the posterior belly of the digastric muscle.
Again, it's about translating a 2D textbook name into a 3D physical location on a patient.
Precisely. And in this case, the name itself is the anatomical coordinate jugulo-digastric. It sits precisely where the internal jugular vein and the posterior belly of the digastric muscle intersect. Let's look at why the distractors are wrong. Option A accurately describes the location of the superficial cervical nodes, not the deep jugulo-digastric. Option B describes the location of the paratracheal nodes, which are deep anterior nodes guarding the airway. And option D describes the location of a completely different deep cervical node, the jugulo-omohyoid node, which, as we discussed, receives lymph from the base of the tongue much lower in the neck.
Great dissection of the anatomy. SBA question 4, which specific group of lymph nodes acts as the final common pathway? ultimately receiving absolutely all of the lymphatic fluid from the entire head and neck before it is delivered to the major lymphatic ducts. Option A, retropharyngeal nodes. Option B, submandibular nodes. Option C, superficial cervical nodes. Option D, deep cervical nodes.
The correct answer is D, deep cervical nodes.
The great catchment basins of the neck.
That is their defining functional characteristic. The text repeatedly emphasizes that while lymph may successfully pass through the retropharyngeal, submandibular, or superficial cervical nodes acting as primary or secondary barriers, it is the deep cervical nodes forming that massive, formidable chain along the carotid sheath that are the most important terminal collectors. They ultimately receive all lymph from the entire head and neck. It is their efferent vessels that merge to form the jugular trunk, which finally exits the cervical system to return fluid to the blood.
Spot on. Final question to wrap it all up. SBA. Question 5. We know extracellular fluid enters lymphatic vessels rather than returning directly to the venous system. What is the primary physical reason for this rerouting? Option A, the fluid contains cells that are physically too large to fit through venous capillary pores. Option B, the pressure of the fluid within the interstitial tissue is less than the venous pressure of the blood. Option C, the fluid must be biologically filtered by nodes before it is allowed to interact with red blood cells. Option D, venules lack the necessary one-way valves to receive extracellular fluid.
The correct answer is B. The pressure of the fluid within the interstitial tissue is less than the venous pressure of the blood.
The motorway slip road analogy in action.
Exactly. This is a question of separating primary physical causation from secondary biological benefit. While option A is partially true, lymph does carry large particulate matter and cells that can't easily cross the venous endothelium, and option C perfectly describes the immune function of the nodes after the fluid enters the system. The text explicitly identifies the primary driving physical force, which is hydrostatics. Fluid exits the arterial capillary beds, but because its pressure out there in the tissue is physically lower than the pressurized venous return, it is mechanically unable to push its way back into the venous system. It must take the low-pressure alternative route into the lymphatic slip road.
Fantastic. That solidifies the core concepts perfectly. We have seen how structure dictates function, how hydrostatic pressure gradients dictate flow, and how accurate anatomical mapping dictates clinical diagnosis and surgical reality.
It is a beautifully logical, elegant system once you understand the physical rules it plays by.
It really is. And as we wrap up this deep dive, I want to leave you, the listener, with a final, perhaps somewhat provocative thought. Consider the profound evolutionary irony of what we've discussed today. The body evolved this incredibly complex, parallel, low-pressure plumbing system simply to clean up the microscopic fluid leaks and debris of the cardiovascular system. It was designed primarily as a passive janitorial service, but in creating this highly networked sequential barrier system, the body inadvertently created the absolutely perfect shielded superhighway for tracking and unfortunately facilitating the spread of cancer. In building a defense network, the body accidentally built a detailed map of its own systemic vulnerabilities.
It is a profound, tragic irony. The very lymphatic system designed to trap, isolate, and destroy microscopic threats becomes the exact pathway by which the deadliest mucosal diseases travel and colonize the body. But here is the crucial takeaway for the clinician, because that map is anatomically constant. Because the jugulogastric node almost always sits at that specific muscular junction, and because the mandibular incisors invariably drain to the submental triangle, we can learn to read that map. We can use the cancer's own highway against it to find the primary source and fight back.
Which brings us back to the contrast we started with. The nervous system tells you what is happening now. It shouts about the immediate pain. But if you know how to read the silent, swollen nodes, the lymphatic system holds the story of what is happening next.
It tells you where the battle is moving.
Incredible. Thank you so much for joining us on this exploration of the silent system. Keep mapping those structures in your mind, keep asking why they are placed where they are, and as always, keep diving deep. Here are the details of this episode.
Lymphatics of the head and neck, the hidden pathways of disease and defense, byline. Not seen, rarely felt, yet these silent channels reveal where disease begins, travels, and declares itself.